Mr. Smith from Nebraska, you're now recognized.
Thank you again to our panel, our entire panel, certainly members for paying attention here today. I think these are important topics, and I'm glad that we can convene and discuss these. It's, I think, important to remember that America is a big country, different needs in different places. Yes, I represent a rural district, and rural means different things in different places across America. And in fact, it means different things in different places across my own district. That Nebraska as a whole, which my district is most of the land area of Nebraska, we only have 3 long-term care hospitals in the entire state. They're all in the east. The population certainly is weighted that way, but that doesn't mean we don't exist in other parts of the state. And so it is my hope that we can pursue policies that are more flexible, that actually meet the needs that exist in more parts of our country than we currently do. It's come to my attention that even small oversights in our current policies can have a very significant impact on an individual's ability to access post-acute care. For example, patients with primary immunodeficiencies are typically unable to receive necessary IVIG treatments because facilities are simply unable to absorb those high costs of their special therapies with a standard skilled nursing facility payment. That's why I introduced the PI Post-Acute Access Act last Congress to include these treatments in a limited list of high-cost outliers which are paid outside of the standard skilled nursing facility payment. I want to mention that I frequently hear from Nebraska hospitals about their frustrations with delays discharging patients ready to leave the hospital because of their inability to gain access to an appropriate post-acute care site. Some of those delays are caused by administrative issues such as prior authorization, but in many cases this is because there just aren't any skilled nursing facility beds available nearby for a patient who really needs one. One way to address this lack of access would be to look at new innovative ways to expand the universe of hospital discharge options. I'm currently working on a new bill which would create a skilled nursing facility at home option modeled after the success of the ongoing hospital at home demonstration. Since the COVID pandemic, we've seen just how much new technologies have expanded the ability of patients to receive care in their homes instead of the traditional facilities. We hear a lot about various things. We heard earlier reference about nursing care staffing mandates by the previous administration. I would say those were political decisions, very expensive ones, I might add, and it has really stressed, if not caused the closure of many nursing facilities, or certainly would if allowed to continue. But I'm concerned that the stresses on facilities, especially in rural areas, the federal government ought not make it even more stressful, especially with unfounded mandates that come out of Washington. I think we can do better than that. American people expect us to do better. But Ms. Grabert, you mentioned the impact of a unified post-acute payment system could have on the post-acute landscape. How would such a system make it easier to provide a skilled nursing facility at home option for our seniors?
Thank you for the question, Mr. Smith. I do think that what you've described is a perfect model that fits under the umbrella of regulatory relief that can be done in tandem with the post-acute care unified PAC PPS. It's a model that would thrive under such a system.
Okay, thank you. Mr. Dongili, again, thank you for your participation here today. Legislation was proposed last Congress to address several key concerns of long-term care hospitals, which included a number of different provisions, such as admitting patients from critical access hospitals, concerns with the high-cost outlier payments, ensuring access for patients with certain complex conditions, and other payment modifications. Which of these do you think would have the greatest impact on your ability to continue serving long-term acute care patients at Madonna?
Thank you for the question, Congressman Smith. Both of those issues would allow greater access for individuals to come and receive services in a long-term care hospital. The high-cost outlier issue is one that is dramatically impacting both access for patients to come into an LTAC, but also the ability for an acute care hospital to manage their ICU and other beds. Currently, when an individual is on a ventilator, say, and requires additional high-cost services like dialysis, for instance, losing $77,000 before receiving an outlier payment because that patient has stayed so long because of the care that they need would deter that LTAC from admitting them. And as a result, that patient might have to stay longer in the acute care hospital and hopefully transition out of receiving the dialysis service before they could admit into the LTAC. Okay. So addressing the high-cost outlier provision would allow greater access, but so would allowing patients to come directly from a critical access hospital. Both are important.
Very good. Thank you again. And thanks to our entire panel. I yield back.